Hello and welcome. I'm Dr. Raj, a practicing anesthesia doctor in USA. Thank you for tuning into our live session on Ask the Experts. Today we will ask our experts questions related to clotting, bleeding, and other confusing things in COVID. Our experts will try to explain things in a very simple language which will be easy for everyone to understand. I want to welcome the live and returning viewers. If you are a returning viewer watching this, remember, this is a long video because we tend to cover many important things. You can always scroll to things that are important to you in the video and also by looking in the description below. So today I'm very honored to have two guests here. Our first expert today is Dr. Meera Shreedhara. So welcome, Dr. Meera.
Um, Good morning, Rajiv, and thank you very much for having me on your show. And I look forward to talking about COVID and clotting and bleeding and vaccine and all other questions viewers might have, and really enjoy the opportunity to be sharing this platform.
Excellent. Thank you for being here. So Dr. Meera is a hematology-oncology expert in Dallas, Texas, USA. Our second expert is Dr. Suresh Krishnan. Welcome, Dr. Suresh.
Thanks, Rajiv. Happy to be here, and we will be trying to explain as much as possible whatever questions the viewers have.
Great. Suresh is a consultant hematologist at Bradford Teaching Hospital, National Health Service or NHS in UK. I have to tell the viewers the most exciting part. So both the experts are my friends. We went to medical college or medical school together and we are all alumni of Bangalore Medical College, 94 batch. Did I just give out our age? It's okay, age is in the mind. So how are you doing, Suresh?
Yeah, I'm fine, Rajiv.
What is the time there?
It's 2:30 UK time,
Great,
2:30 in the afternoon.
great. It's 9:30 for me here. People always blame about UK weather. How is the weather there today?
Luckily, it's summer now, but it's around 23 degrees Celsius. That's the
There,
maximum we get.
there you go. Well, if you're here for the first time or still not subscribed, I encourage you to subscribe and hit the bell icon so you get an update when I release or I am about to release a new video. Hit the thumbs up like button and share this video so more people can benefit from this. Do type your comments below if you have any questions and I will try to get to as many as possible. If you want to join live with us to ask a question, I will leave the link in the comments and you can simply click on it to join to ask a question. So, Dr. Suresh and Dr. Meera, so initially people were so worried of COVID, they took all precautions. Unfortunately, some people did get COVID and they recovered, which was very exciting. And now there are reports of people having sudden death after COVID, even after they have recovered. Like this is a news report from, that says COVID-19 patient deaths even after recovery worries doctor. So can you tell us what's going on?
So yes, Rajiv. So as we know, this whole COVID pandemic has evolved literally in front of our eyes over the last 16 to 18 months. We have seen how the disease has changed. We have learned more about the disease, and now we know a lot more about disease and management compared to what we knew before. So to what you mentioned. COVID-19 is a viral illness where the big morbidity and mortality, or people what they get sick from COVID-19, is not exactly due to the damage the virus does to the body itself. I think the bigger problems occur due to the host or our own body's immune response to the virus, and that is very varied across different geographic populations, ethnicities, comorbidities. So we are seeing a wide variety of host responses to the virus, which can explain some of the wide varieties of differences we see in outcomes. So to what you mentioned about some of the sudden deaths or the later deaths that occur in people that are so-called recovered from COVID, one of the bigger issues is blood clotting. So coagulopathy, that is typically what we call that term. And that is something that is seen very frequently with COVID-19 infections. And again, it also to some extent depends on the severity of the illness the patient's underlying comorbidities. So COVID-19 is a prothrombotic illness. To make it more simpler, when you have a COVID-19 infection, depending on the severity of the infection, you are at higher risk for developing blood clots. So what are blood clots, and what do they do, and how do people die from them? So again, blood clots can occur in variety of parts of the body. Not all blood clots lead to death. The kind of blood clots that we see, or some of the reports that we are hearing, are mainly due to what we call pulmonary embolus, or a blood clot that is then transmitted to the lung. So typically, that can be an immediately life-threatening situation. Sometimes patients also have thrombosis of their vessels or blood clots in the brain. That can also cause some cases of immediate death. But there's also this big incidence of what we call sudden cardiac deaths that occur or have been reported to be increased after a COVID-19 infection. And if you look at out-of-hospital cardiac deaths versus in-hospital cardiac arrest, there has been an increase in both out-of-hospital cardiac arrest and in-hospital cardiac arrest whenever there is a huge surge in COVID. So some of the in the reports that we are hearing about sudden deaths after COVID are usually not related to just respiratory problems or those kind of issues. They're more related to clotting problems. So I think that is why we have to understand that COVID-19 infection is a prothrombotic illness, and kind of manage it and accordingly.
Okay, that's great. So, Dr. Suresh, do you want to tell us, just summarize and say, does COVID-19 increase the risk of clots, and who are the people who can get the clots? So, if I have COVID-19, can I get a clot?
Yeah, as Meera pointed out, COVID-19 is a prothrombotic. So for some reason, it increases, it causes microthrombi, patients who have COVID-19. And microthrombi can affect any part of the body, mainly lungs, as Meera mentioned, PE, or it can affect your brain, called sinus thrombosis. It can happen in any part of the body, even DVT and mesenteric vein thrombosis. So why some people get, why others don't get, it's still being investigated. But
Okay.
what we know till now, uh, most the patients who are high risk to develop thrombosis are, if they're not mobile following COVID, if they're immobile, obese patients their chances of developing blood clot goes high. And if they have underlying cancer and if they get COVID, again, their chances go high as well. So there are quite a variety of factors which increases the chances of blood clot. And our main aim is, as soon as the COVID patient gets admitted, our main aim is to prevent the blood clot from happening uh, with whatever means available and tried and tested till now.
Okay. So, sounds like, it's important to maintain a healthy lifestyle, have some physical activity. So, I want
Yes.
to tell our viewers, watch the video fully and then go out for a walk and get some physical activity.
Yeah, it's better to
The
be fit.
point, Rajiv, you mentioned physical activity, and like Suresh said, I think that is a big risk factor. During COVID, specifically, I'm going to address the risk factor of physical activity and COVID in relation to blood clots. Is also because a lot of our COVID patients, historically, whenever we are diagnosed with COVID, the first thing we do is we want to isolate these patients, we want to put them in quarantine. So blood clots occur in two different major populations, right? There is one, the outpatient home isolation that is typically not very sick, and they are under home isolation. And then you have the sicker inpatient hospital patients, who again you can stratify into the mild and moderately sick patients who are not very sick, and then there are ICU level patients. So the role of physical activity is important in blood clots, because especially in the outpatient population, the first thing we do is isolate these patients. And depending on individual circumstances, if we just isolate a patient to stay in a room for 14 days, chances are that person is going to sit on a bed or a chair or something and is not going to be very mobile. So one of the biggest risk factors for blood clots is immobility, and we see this very frequently in patients who've had orthopedic surgery or any kind of surgery, and that is not because of the surgery itself, it's because they're immobile after surgery. Of course, in the hospital, we are able to manage that with preventive medications and such. But in a home isolation patient, if you're going to take somebody that is obese, has hypertension, has diabetes, probably a smoker or something like that, who has multiple other risk factors, now you have a prothrombotic illness, and then you're going to isolate them without being educated about the need to be mobile. If you have a sedentary person for 14 days or longer, I'm sure that does add to some of the immediate and delayed risk of blood clots that develop. So I think this is another area where we can educate patients that even if you are on home isolation, make sure you're not very sedentary during that whole time.
Okay, that's a great point. So let's say, I have COVID. I recovered out of COVID. Now I'm feeling perfectly fine. Maybe I have a risk of developing clots. So how do I know? Like, what symptoms would I have if I were to develop any clots after recovering from COVID? Otherwise I'm feeling perfectly fine.
So yeah, I will take this. So the main symptoms are what you can notice from blood clot. If it happens in your limbs, basically your limbs will get swollen. So swollen legs, swollen arms, they are sign of blood clot in the limbs. And if you get sudden onset of chest pain, shortness of breath, it indirectly means there could be a blood clot in your lungs. So any patients who are recovering from COVID, if they develop any chest pain or shortness of breath, it's better they consult the doctor straight away. But blood clots can happen all over the body. So even if you get headache, persistent headache, blurred vision, it's a sign of cerebral venous thrombosis. So again, that's a life-threatening situation. Patients with abdominal pain, we have seen patients presenting with abdominal pain to the surgeons post-COVID, and they unfortunately have mesenteric vein thrombosis. It can happen in any part of the body, as I mentioned before. So you can get abdominal blood clots as well. So any unusual symptoms, it's better to consult the doctor straight away, because COVID per se, the main reason people die is because of the blood clots, and it's a high risk mortality situation. So it's better to consult the doctor if they have any concern or if they have any unusual symptom.
Okay. Can people do any tests to know if they have COVID, like clots related to COVID?
So yes,
Yes.
yeah, go ahead. Most patients that are, so we're going to talk about two different populations because they are kind of managed differently. One is your, average COVID patient, which is most of our COVID-19 patients who are asymptomatic or mildly symptomatic and are being managed at home. What kind of intervention would they need versus your sicker patients who are either in the hospital or in an ICU. So those are two different populations with vastly different risk factors and risk for developing COVID. So typically in an outpatient population, like for example, somebody that's not very ill who is being managed as an outpatient, typically, at least here, we don't recommend checking for routine blood parameters that measure for blood clots. I'm sure you've heard about many blood tests that we do, things like D-dimers and things like that. If a patient is completely asymptomatic, they typically don't need all of these parameters to be monitored. Again, it goes down to risk factor reduction. So if you're a smoker, don't smoke. If you're hypertensive or diabetic, make sure you have good diabetic control. Be mobile, don't be sedentary. So these would be the things to watch out for. I think monitoring pulse ox has been a very game changer in managing a lot of COVID-19 patients, even at home, because we've seen that a lot of these patients get what we call happy hypoxia, meaning they look fine, they feel fine, but very drastically, we've seen their oxygen levels drop very quickly. And this can happen in an outpatient setting too. So frequent monitoring of blood oxygen levels has also been important identifier for these COVID-19 patients at home. So I think there is not really a role for doing routine D-dimer testing, and I will go into that in a moment because
Mm-hmm.
Those tests that kind of indirectly give us a measure of clotting going on can be quite highly elevated in a COVID-19 patient just because of the COVID-19 infection itself, and it's like an inflammatory marker. So it may not necessarily reflect having a blood clot. So for the outpatient, there is probably not that big of a role in monitoring or checking these blood parameters. I think monitoring clinical findings is going to be more important. Now, coming to the inpatient population, there is going to be your moderately sick that are in the hospital, and then the very severely sick that are requiring mechanical ventilation, ECMO, those kind of things. So those are the patients we have to be very careful about monitoring for blood clots, and also probably prophylactically or preventively treating them with what we call anticoagulants or blood thinners, because they are going to be at a higher risk for developing clinically significant blood clots. And there are some of the tests are, the most common test that we use is something called a D-dimer level. D-dimer levels are elevated when there is an active clotting process going on, but D-dimers can be elevated in a lot of other situations too. So an elevated D-dimer level is not necessarily a marker for having a blood clot, but what it is helpful is if the D-dimer is low or negative, that is pretty sensitive to rule out a blood clot. So D-dimers levels are used pretty frequently in inpatient settings to monitor patients that have or at risk for blood clots. There are a lot of other tests that we use, things like fibrinogen, which also are indicative of the actual clotting system, how the clotting system is working. So it's a little nuanced, description. You have to try to differentiate having a COVID-19 coagulopathy from something very similar called DIC, or it's called the long form is disseminated intravascular coagulation, which can happen in pretty much every infection, every sepsis patient. So it's kind of hard to differentiate sometimes between the two.
Okay.
But bottom line is, if you are suspecting a patient that has extremely high D-dimers, and if you're suspecting a coagulopathy, the tests that we use to diagnose blood clots are something called Dopplers or ultrasound Dopplers, which are fairly easy to use. They can be used at bedside, and they are used very commonly to detect clots in the extremities, like your lower extremities, upper extremities, and things like that. Clots in the lung can be a little harder to diagnose without the use of equipment. So typically requires things like a contrast chest CT or a ventilation perfusion scan. So again, in low resource settings, this patients may or may not have access to this. So it is important to prevent coagulation in these patients.
So for non-physicians, to summarize, just watch for your symptoms. Don't get any test done without talking to a doctor, and don't fall for
Exactly.
any trap,
So
and don't go to the lab just getting tests done. This won't be helpful, right?
yes. So in an outpatient setting, if you just get a test done without a physician understanding why you're ordering the test and what they're going to do with that information, it can be very hard to interpret that information, and it can cause unnecessary anxiety to the patient as well. Because
Sure.
9 times out of 10, if a COVID-19 patient goes and gets a D-dimer test, it is going to be high. It doesn't mean that they're all going to get blood clots. So monitor clinically, I think, is more relevant.
Okay. So we have some questions from the audience on prevention and treatment. So let me get this on the screen.
Mhm.
So this says, what is the medicine and how long should you give in someone who's recovered but at high risk for heart problems or any stroke or any clots?
So I can take this. So I think the question is, this is somebody that has recovered from what I'm assuming is probably an asymptomatic or a symptomatic infection, who probably has not had any blood clotting problems. So the question is, does somebody need to be on preventive blood thinners after recovery from COVID? Well, this is currently being looked at because, to be honest, just kind of going back, the biggest game changer in the management of COVID, since we have understood this illness, is really 2 things. One is the use of corticosteroids, which is dexamethasone or any of its similar corticosteroids. And the second big game changer has been appropriate use of anticoagulation or the use of blood thinners. But Blood thinners can be a double-edged sword, and it is certainly not a one-size-fits-all type of treatment. As of now, multiple societies, like we have American Society of Hematology, we have the chest physicians group. We currently do not recommend routine anticoagulation or blood thinners for recovered patients from COVID. So the reason is these are not simple, medications. They have a risk of bleeding. So we have to be very careful about who we recommend this to. So not all patients who have recovered from COVID require blood thinners to prevent blood clots. The reason being, it's still a very small risk. If you look at it, when the COVID-19 first started, when we were looking at cases in Italy and then New York, the risk of blood clotting was as high as, we've seen numbers as high as, 60% as well. But lately, with appropriate management and better recognition, the incidence has dropped significantly. So not all people need blood thinners. What we typically do is go by recommendation. So there's a lot of guidelines and recommendations, but eventually it boils down to an individual clinical decision based on that particular patient's risk or benefit. So it's not going to be a one size fits all. So the simple answer is no, not everybody that has recovered from COVID needs to be on blood thinners. Somebody that has had a very prolonged hospital stay, who probably is expected to be immobile even after discharge, somebody who probably has multiple other uncontrolled risk factors, or let's say they have a history of cancer or recent surgery, those would be somebody who we would think of discharging home on some dose of blood thinner. And usually it is for about a couple of months. It's not longer than that. So no, it's not a one size fits all.
Okay. So Suresh, just to add on that, what do you think of aspirin? Should people routinely take aspirin after COVID infection?
I think no is the short answer, because we in UK they did a trial called recovery trial, and they completely ruled out the benefit of aspirin in COVID patients. Again, as Meera mentioned, COVID patients can have thrombocytopenia or low platelet count. Uh, if you give aspirin, that can make things worse. So again, it depends on where you work. In UK, I don't think aspirin is indicated post COVID.
Okay.
We prefer low molecular weight heparin or tinzaparin in patients who are still symptomatic on discharge. I know we are taking the risk of bleeding, but again, patients are being counseled. If there's any history of bruising or bleeding, they need to let the doctor straight away know. But we do give as a thromboprophylaxis low molecular weight heparin post-COVID patients rather than aspirin.
Okay, so you shared your UK experience. So how about people in India and other low middle income countries, Pakistan, Bangladesh, Nepal, Africa, just to mention a few. What should people do there?
So coming to aspirin, the question about aspirin, I'm assuming you're talking about what we call the low dose aspirin, either 81 or 100 milligrams, depending on what country you're in. Aspirin has been looked at extensively to see if it, can be used as thromboprophylaxis. And the short answer, I think, is no. Like Dr. Suresh said, aspirin is actually not a blood thinner. So in India, and of course, for many lay people, the blood thinner is a very vast terminology used. But there is a difference between an antiplatelet drug and an anticoagulant drug. So aspirin is basically an antiplatelet drug. So it really does not really prevent venous or blood clots in the veins. That being said, there has been some studies looking at, especially in orthopedic literature, about using aspirin, especially here, as a way to prevent post-orthopedic procedure blood clots. So aspirin has been looked at in that setting, but in general, they found that it's not very effective. So do we want everybody to be on aspirin? Probably not. But if somebody already has cardiac risk factors and they have other risk factors, cardiovascular risk factors that might, increase the risk of, platelet activated type problems, like if they're having a risk of stroke, if they are high risk for developing a heart attack, they have multiple cardiovascular risk factors, I think low dose aspirin is not unreasonable to start during a COVID infection and probably even continue thereafter. Typically, with aspirin, we tell patients not to use it on an empty stomach. So
Yeah.
I don't think it has to be used in a way to prevent blood clots, because I don't think it does. But generally, blood clot is just one of the problems. These patients are also at risk for cardiovascular complications post-COVID. So it is reasonable to consider using it from a cardiovascular standpoint. So, and especially patients who have already been on aspirin, I think there is no reason to stop it. We are recommending for them to continue it. But certainly, like Suresh said, it is an antiplatelet drug, and it is not either treatment or prophylaxis for venous blood clots.
Okay. So, if our viewers are thinking what is going on, I'm a physician and I'm very confused with all this because COVID is a new disease. There are a lot of things that's coming up. It can be very confusing. So, bottom line, if you're on aspirin, continue aspirin. If you're not on aspirin, don't take aspirin unless you speak to a doctor, and don't take any blood thinners unless you speak to a doctor.
Absolutely.
All right. So we see our next question that says, Suresh, what is
Yeah.
the clotting problem that you and other doctors are seeing in severe COVID-19 cases?
Yeah. So COVID per se, as we have already pointed out, it's a prothrombotic agent. But severe COVID patients, they do cause what we call as COVID-19 coagulopathy, where as Meera mentioned before, they go into DIC, what we call as COVID DIC. So clinically or from the laboratory point of view, what we can see is in these patients, the D dimer goes high, sometimes 3 times the normal. As Meera mentioned, D dimer is not a specific marker, but when combined with all others, like the platelet count can go down in severe COVID or severe DIC. Then the fibrinogen level, what we call as hypofibrinogenemia, or the fibrinogen level goes down as well. So these patients, uh, they go into DIC, and even though we tell COVID is prothrombotic, when they go into DIC, they can still bleed. Uh, Coming to the aspect of platelet count, if the platelet count goes down, you need to you need to be cautious, because these patients, if they are diagnosed as having thrombosis as well, and if the platelet count goes down, you need to monitor, because if you keep on giving heparin or tinzaparin when the platelet count is going down, then these patients can bleed. So we have a rule: when the platelet count goes less than 25, we stop the anticoagulation or the low molecular weight heparin. Between 25 to 100, if the platelet count is during that range, we do give, if they have underlying blood clots, we still give tinzaparin around less than the normal dose, like 100 microgram per kilogram. But if it is more than 100, we give them the full dose. So they go into severe, short form is they go into severe DIC. They need to be monitored regularly, and you need to change their treatment options depending on what you find.
Yeah, so I agree with that. So Rajiv, to add to your question about what are we seeing in the hospitals, and Dr. Suresh was completely right. We are seeing this process called DIC. We're also seeing COVID-19 related specific blood clotting problems. So to explain in a simple language, COVID-19 related blood clotting problems can occur in the large blood vessels, like having a blood clot in your lungs or blood clot in your brain where you have a stroke, or it can cause blood clots in your abdomen. So those are the blood clots that occur in your large vessels. But it can also cause blood clots in your small vessels, which typically are not as dramatic as when you have a blood clot in your lungs or brain or stroke. So those are the ones that Dr. Suresh mentioned. We have to monitor the blood count and other parameters to understand that there is blood clotting going on in the smaller blood vessels, because what you will see in the hospital is somebody is on a ventilator, their oxygen levels are low, and no matter how much oxygen you're giving them, their oxygen level is not going up. So these are the kind of clinical problems you will see. But what is actually going on is there is blood clotting in those micro vessels in the organs, and hence they are not getting the perfusion that they are needing. So that is why you could be giving 5 liters of oxygen, 10 liters of oxygen, you can put them on a ventilator, but you're not going to see those lungs perfused because of what we call as a microthrombus injury that is going on. So that is the more subtle form of blood clots that we don't really recognize as blood clots. When we see blood clot in the lung, heart, lower extremities, it's pretty obvious and we can manage it. But when it occurs in microthrombi, it requires a more of a closer monitoring of parameters to manage that. That's what we're seeing before we introduced this concept of prophylactic anticoagulation. So that is what we have learned over the year, is that now that we know that COVID is a prothrombotic illness, we are introducing blood thinners much early on in the management of COVID. So we typically don't see these dramatic blood clot problems as much as we used to see before.
Okay. So, in your experience for those patients on home isolation, Suresh, when do they present to you with symptoms of clotting?
So, so home isolation, you mean mild COVID?
I would think so. You can think of anyone having a home isolation. This is
Yeah,
being pretty
usually,
common in India and
yeah.
other
So,
countries.
so patients sit on home isolation when they present with blood clot. That's what I meant. Yeah.
Yeah.
So patients who are on home isolation, usually they are mild. Yeah. If they are moderate or severe, they need to be hospitalized anyway. So mild patients, they do well, but again, if they have underlying risk factor like obesity, immobile, if they are immobile, and if they have underlying any cancer issues, or if they already have history of blood clots, their chances of having a blood clot goes high. So usually we we I mean, COVID is around day 10, we feel is the worst phase when someone has a COVID infection, and these patients can present around day 10 post COVID exposure. Again, they can present with any chest pain or shortness of breath or limb swelling. So these symptoms, as soon as they mention or they present to the doctor, it should ring alarm bells that there could be an element of underlying blood clots, and it needs to be investigated, as Meera mentioned before, with Doppler scans. That Doppler scan is the only way you can diagnose a blood clot, because D dimer is not a specific blood test. It's as long as they're actively mobile, and they are taking adequate precautions, you can prevent the blood clot in mild COVID patients.
Okay.
That's why we mentioned the public to be as mobile as possible. I know they are at home quarantine, but even though they're at home, it's better to be actively mobile rather than sit in one place, so that at least the circulation keeps going, and it will prevent the blood clot from happening.
Sure. Okay. Thank you. So, Meera, you mentioned about D dimers earlier. So, how long can these D dimers be elevated after COVID infection?
Yeah, so this is a great question. And this is one of the biggest challenges we see in our practice, because we have D-dimer is a test that can be elevated for a long time after a COVID infection. And one of the biggest challenges we have, or one of the pet peeves that we have, is doctors or patients checking their D-dimers themselves. Let's say 2 weeks or 3 weeks after a COVID infection, they're completely asymptomatic. They now have a D-dimer that is still high, and they want to know what to do about it. So this is again a situation where it is important to know why you're ordering a test, know what is the purpose of ordering a test and what you're going to do with that information. So D-dimer is a specific test that is a marker for inflammation. It is a marker for coagulation as well. So it can be elevated when you have an active COVID infection. It can also be elevated when you have any active blood clotting process going on. but it can stay elevated for a long time, sometime even up to 4 to 6 weeks after recovery from a COVID infection. So we typically do not initiate any form of blood thinners or management based on just a D-dimer level. So that is kind of the worst thing we see is somebody comes to you with a D-dimer. I had COVID 3 weeks ago. I decided to get a D-dimer test because I saw it on the internet and now it's high. Should I be a blood thinner? The answer is no. Not everybody that needs or has a persistently high D-dimer needs to be a blood thinner. And again, with the D-dimer, there is classifications. How high is it? And every lab has D-dimer is measured in different ways in different labs. So we kind of have to look at that particular lab's reference value. And typically mild elevations of D-dimer are just reflective of a recovering COVID state. Anything more than 2 or 3 or 4 times higher than normal, that is when we start getting a little concerned about it. And it also depends on how severe was their COVID infection. So typically patients who had prolonged hospital stay, let's say they were on a ventilator, these are the patients who we worry more about. But if it's an asymptomatic patient that has a persistently elevated D-dimer, a lot of time all they need is some reassurance.
Okay, great. So this is probably a physician who is saying one patient had a blue painful hand but still had a pulse, which means for non-physicians, I want to say if there is a pulse, it means the blood is circulating. So what could be the possibility here? Could it be arterial clots, emboli, or what is it?
Sorry,
Suresh?
I didn't get that. So I didn't get that. Sorry. What's the
The
one
one
finger?
patient had a palpable distal pulse but
Okay.
cyanotic painful hand. What could be the possibility here? Could it be arterial clots or emboli?
I mean, you need the full picture. Whether the patient is suffering from is he suffering from COVID or no?
I would think so because we are talking of COVID. So I would think this is probably someone who is.
Hi, Daddy. Why are you talking to the laptop?
So I mean,
There you go. You're going to get viral now.
Okay, hold on. Just say hi.
no,
There are a lot
hi.
of people watching us.
All right.
Yeah, good.
In a COVID scenario, I mean, there are 2 scenarios here, whether it's COVID or vaccination. I mean, we'll come to the vaccination later. In the COVID scenario, if the patient is known to have COVID, I mean, if he presents with a purple finger, then first thing you need to look for is it a blood clot? Most likely, the way he's presenting looks like an arterial rather than a venous blood clot. But COVID can cause blood clot anywhere, so it needs to be investigated. Again, if he has underlying cardiac issues, that can cause blood clots as well. So in a COVID scenario, yes, it needs to be investigated, and he needs to be started on treatment dose tinzaparin or whatever the trust policy is, and investigate further with relevant blood tests and with relevant scans.
Okay.
I completely agree with Dr. Suresh, but another point, if they have a distal pulse that is still present and their finger is getting ischemic, I'm assuming they've already done some imaging to make sure there is no major arterial thrombus. You're now starting to think of, could this be embolic? And just for our non-medical viewers, I'm going to try to differentiate the two. So a clot in a big vessel that goes to your artery, if there is a clot there, that means it's going to cut off blood circulation to a lot of the fingers and other organs below that. So that is one form of clot. There is another form of blood clotting that can occur, which is called emboli, meaning there is a bigger blood clot somewhere, either a blood clot or an infection or somewhere, and it sends these showers of little blood clots to smaller blood vessels while maintaining the circulation in the bigger vessels. So that is called an embolic phenomenon. And usually if we are suspecting that, it's not enough to just look at that extremity. You have to try to dig deeper to find out if there is another source for that embolus. Sometimes it can be something like a hole in the heart, or it can be something like endocarditis, which can occur in these patients, which can cause infection in the leaflets of the heart. So typically, when you see the shower of emboli, you kind of have to go further up, all the way up to the heart, to make sure there is no focus that is showering this emboli. So to answer his question, if there is a good pulse and there is a finger that is blue, that patient probably, in addition to what Dr. Suresh said, is going to need a little bit of a workup to make sure there's no other sources of emboli.
Okay, great. So, Suresh, is there any role for high-dose steroids in severe COVID infections? So I assume this is to prevent clots.
I mean, the only thing which came out of the recovery trial is high dose steroids in patients with COVID. That works well. Bottom line is COVID, the high dose steroids, they prevent you from getting inflammation. Indirectly, I mean, if you go to the pathophysiology for a blood clot in COVID, it's due to inflammation basically. So any sort of inflammation, what the body response is to form blood clots. So patients who have steroids, their chances of blood clot happening can be less. But as everyone knows, we are in a dynamic situation. Things change every other day. But steroids is beneficial in severe COVID patients. There is evidence that it does prevent blood clots.
Okay.
Agreed.
So this is probably a very doctor-specific question. So patients are being sent home on Enoxaparin, which is an injection to be taken at home in India, but they cannot go to the hospital as they're still in isolation. Is Apixaban, which I assume is an oral medicine, a substitute in that circumstance?
Yeah, I can take this. So the patients that are sent home on blood thinners are usually, at least I'm going to talk from a perspective what I've seen here. At the time of discharge of a patient, we have to carefully risk stratify that patient into high, low, or intermediate risk of blood clotting. So if somebody is at a high risk for blood clotting, there is some data to suggest that they might benefit from some form of blood thinner therapy even after discharge. Again, this is not a uniform guideline yet. In fact, there is a big trial enrolling in Duke where they are looking at this particular thing before they make a recommendation, is whether we can send patients home on Apixaban, which is Eliquis, 2.5 milligrams instead of Lovenox or instead of no medication. So that trial is still accruing. Even the American Society for Hematology, although they don't routinely recommend sending patients home on blood thinners, they have put this caveat saying individual physician clinical discretion can be used. So if as a clinician we feel that somebody is at a high risk, there are many physicians and many institutions that are still sending people home on some low dose of Lovenox, which is low molecular weight heparin. This is injectable, and most patients are trained to give it to themselves. It is like a subcutaneous, like an insulin injection. They can give it to themselves. But if that is not possible, Apixaban or 2.5 milligrams of Apixaban is a reasonable alternative. The only caveat being heparin or any form of heparin like Lovenox, the risk of bleeding is a little more manageable in that the bleeding risk is slightly lower, and the bleeding is a little more easier reversible if they have a bleeding complication. Drugs like Apixaban, Rivaroxaban are a little harder to reverse if there is a bleeding complication. So as long as the treating physician understands that nuance and the risk, I think it is reasonable to substitute Apixaban for Lovenox to answer that physician's question.
Okay, so I do see a comment that says I have seen a few patients, even younger, who have developed retinal vein occlusion a few days with retinal artery occlusion. So which means the blood to the eyes are blocked. So I assume this resulted in severe loss of vision. So thank you for sharing that.
Yes, so, and I think this again goes to the alluding to the fact that COVID can cause microthrombi. So these are small vessels, and microthrombus or small blood vessels can get affected with COVID. And we have had some of our ophthalmology colleagues in our own medical college group who have reported patients who have come in with sudden onset of vision loss. So again, it is a very small number of patients, it's still a small percentage. The data is still evolving, but it is still not a reason to put everybody that is discharged or had COVID on blood thinners. So.
Okay. So, Suresh,
Yeah.
COVID already has low platelets. So, what is that
Yes.
number where people should be worried about?
Yeah. I mean, as long as if they're at home, if they're not bleeding or bruising, number doesn't matter. But in a hospital scenario, that's when we get concerned. If they are on blood thinning tablets or blood thinning injections, platelet level is a concern, because the lower the platelets, if they have underlying blood clots, we can't give adequate medications to prevent the blood clot from happening, like Enoxaparin or Apixaban. Uh, but if they're at home, if the platelet count is down, and if they are perfectly fine, if they are asymptomatic, if they're not bruising or bleeding, it's something which can be watched, because at the end of the day, COVID is an infection. Any infection will drop the platelet count. Once the infection gets better, they recover on their own. But again, if they're bleeding or bruising with the platelet count dropping, that's when we get concerned. Are they going to DIC? In those patients, definitely they need to get admitted. If there is any suspicion of any bruising anywhere with low platelets, they need a doctor's input. But just because the platelet count is dropping doesn't mean they need to get admitted. Uh, Hopefully, it will recover on its own.
Okay. So, we do have a few questions to cover. So, moving on, it says patients with documented pulmonary embolus, which is a clot in the lungs,
Mhm.
would you consider it provoked and do 3 months of treatment, or would you do 6 months of treatment, considering it unprovoked?
So I'm assuming
I
the question is asking, that
go
after
on,
COVID
Hima.
infection.
Yeah, Meera, you can answer this.
So I think the question is, if they have a blood clot in the lungs due to a COVID infection, how long do you keep them on blood thinner? Is that the question that I'm hearing? Yeah.
I think so.
So yeah, so it is considered a provoked infection at that point, a provoked blood clot at that point. So most of us still, it also depends on if it is a massive pulmonary embolus, like a big pulmonary embolus. If I'm seeing that they are having a large pulmonary embolus that was causing them to be hemodynamically unstable, if they had other DVT and other risk factors, I do tend to keep them on blood thinners closer to 6 months rather than 3 months. But if it is just a very mild pulmonary embolism, which was very small, incidentally detected, they were not very sick with that, it is still considered a provoked infection, blood clot, and I would probably lean towards 3 months of anticoagulation. So if it is a very dramatic, hemodynamically unstable pulmonary embolus, I'm usually lean towards keeping them on blood thinners for 6 months. I hope that answers the question. Of course, this would still be considered a provoked clot, so there would not be an indication for lifelong blood thinners, because there is also that scenario when somebody comes with a pulmonary embolus. We are asked often, does this patient need to be on blood thinners lifelong? The answer is no. I think 3 to 6 months, depending on how severe the illness was, I think is reasonable.
Okay.
Yeah, completely agree.
So, Suresh, if let's say someone gets discharged home on anticoagulants, like
Yeah,
the drugs you mentioned, what precautions should the patient be taking when they're home?
yeah. I mean, even even though they are on medication to treat the blood clot, they still need to take precautions from developing or making the clot worse. The main thing, the important thing is to keep them as mobile as possible. Even if they are immobile or sitting in the chair, they need to move their arms and legs. At least the circulation keeps moving. Uh, and if they are mobile, don't sit in one place for a long time. Just try to be as mobile as possible. And any long distance travel, I think they need to make sure they drink plenty of water, make sure they're well hydrated. This prevents the blood clot from happening again, or it helps to prevent the clot getting any worse. So well hydration, any long distance travel, well hydration, mobility, and you need to take precautions. I mean, females who are on pills, I think they need to avoid estrogen containing pills, which increases the chances of blood clots. So these are all preventive measures which you take in any other patient as well, even though whether they have COVID or not, all these precautions are taken in the past for other blood clots. The same thing applies for COVID too. As long as they're mobile, they need to be as active as possible and avoid all medications which increase the chances of blood clots.
Okay, great. So, Meera, the next question is an obese teenager with COVID as much at a high risk for clotting compared to obese adult?
Oh, wow, great question. I would say the answer is no, because in addition to obesity, age is also a very big risk factor for developing blood clots. So patients that are older, typically older than 55 years, are considered to be at much higher risk for developing blood clots. Probably also because at that age, they are more likely to have other comorbidities like hypertension. Somebody that's very obese more likely has some kind of a metabolic syndrome. They're either going to have hypertension or even pre-diabetes, which are all risk factors. They're probably going to be less physically active than a teenager. So technically, a teenager that is obese is probably going to have a much lower risk of developing a blood clot than an adult who is obese. And that is just the age is independently a huge risk factor for developing blood clots.
Mm-hmm. All right. So, Suresh, I do see a comment that says, I do see young patients who present with retinal vascular occlusions, which means clot in the eyes. They usually present 4 to 5 weeks after testing positive for COVID. So, what blood work should they be getting, or what other workup?
It's a great question. We are still
Yeah.
learning about COVID.
Yeah.
Everyone, it's only 1 year down the line. So, I mean, unfortunately, the blood clot can happen at any time. Uh, we still have seen patients who are 3 months down the line presenting with blood clots. So what do you do? As long as you can't keep them on blood thinning tablets forever, because that has its own side effects or risk factors, because they can bleed. So we are trying to balance as much as possible. If they are presenting 4 weeks post COVID, unfortunately, you could not have done much different. You could have given him blood thinning injections or tablets, depending on what the situation was. But if they are presenting, these are late COVID. Unfortunately, we are seeing more and more patients. What different can be done? It's it's anyone's guess or anyone's. It's a clinical discretion.
Yeah.
Unless Meera want to
Completely
add
agree
anything
with that.
controversial as well.
To add to the whatever you just said, Dr. Krishnan, I think you were completely right. It is hard to predict who is going to get a late complication from COVID or not. Again, this may be a little bit of a more nuanced discussion. I'm assuming there are some physicians in the group who are asking questions, so this may be directed more towards them. One thing we have seen, although not very commonly, but it can occur, and this is something we have started to look at for patients who are presenting with late onset blood clots. Some of these patients can have something called anti-phospholipid antibodies. Again, I'm trying to go a little deeper, may not be for all non-medical audience, but there has been a detection of anti-phospholipid antibodies sometimes after a COVID infection. Again, very rare, but has been recognized. And the reason this is important to identify, so if you see somebody that has presented with an unusual blood clot, so usual blood clots are blood clots that occur in the leg, blood clot in the lung, a heart attack or a stroke. But if you see unusual blood clots, like located in your cavernous sinus or mesenteric vein or retinal hemorrhage, you start thinking a little outside the box, and you want to start thinking, could this just be COVID, or is there something else playing in there? And antiphospholipids sometimes can present after a COVID illness and can result in unusual blood clots. The management for that is a little different. We typically don't just put them on Apixaban or Lovenox because it's not that effective. we usually have to treat these patients with warfarin. So I think if you're seeing somebody that presents with an unusual blood clot 4 to 6 weeks after COVID, especially after asymptomatic infection, especially in a younger person, probably requires a little more testing, a little more deeper dive, and then just assume that it is COVID, just because these patients are likely to present with other blood clots elsewhere. Again, it's a very, very rare situation. I don't want our viewers to think this is going to happen to everybody. Again, all of this blood clotting problems that we're talking about is still extremely rare. Majority of our COVID-19 patients, more than 95% of them, recover uneventfully with no complications. So I don't want this discussion to be thought of as a something that everybody's going to have and everybody's going to need. So just to answer that additional thing, because we recently saw somebody that had transient antiphospholipid antibodies.
Mm-hmm. Okay, great.
There
So
could be other cause. That's what Meera meant, rather than blaming on COVID for each and every blood clot.
Exactly. Right. Right.
okay. So let's say ginger, we have a question on a natural product. We can't live without it. So ginger, garlic, and other natural products reduce platelet count. So let's say I have COVID, I eat ginger garlic masala every day, which also helps with physical distancing of the smell. But are they beneficial in preventing clots?
The short answer is no.
No.
I mean, you can take. I mean, no one is stopping you from taking it, but there is not much evidence behind it. But whether it will prevent you from developing a blood clot, I mean, you,
I
you
mean,
could
that
do.
being said, we use a lot of natural products for a variety of reasons. And if it's something we're all using on a daily basis in moderate doses, I don't think they are going to affect one way or the other. The problem occurs when somebody reads on the internet that ginger reduces blood clots or turmeric reduces blood clots, and now start taking mega doses of that, thinking if a little is good, then a lot must be better. So that is the problem when we see somebody is really going overboard with taking some of these natural supplements. These natural supplements, natural products found in our food, I'm sure have a lot of beneficial properties as long as they are taken in moderation. But we, unfortunately, in our practices too, see people that have taken mega doses of ginger, turmeric, or something. And it may be important also in a patient, let's say we're sending somebody home on blood thinners, we don't want that person to be taking some mega doses of a natural supplement that we don't know how it's going to interact with their medication. So anything done in moderation, I think, is fine. But is it going to reduce your risk of blood clot? I would not rely on that.
Okay. So we talked a lot about clotting, but there are reports of bleeding in the gums, bleeding in the brain with COVID. So where does this happen, and what do you want to say about it? Suresh, if you want to go.
Yeah, I mean, as we mentioned, briefly touched on this before. I mean, COVID is a prothrombotic agent, but still patients can bleed as well. Again, that's where the DIC come into the picture, where you can drop your platelet count with severe COVID. If you drop your platelet count, you can bleed anywhere, uh, any part of the body. It doesn't matter. Again, if your fibrinogen level goes down, you can bleed. That's another risk for developing bleeding in severe COVID. How do you treat it? I mean, you need to, if the platelet count is low, you just need, I mean, you need to, initially you need to stop all the anticoagulants, or sorry, whatever you're using to prevent the blood clot, like tinzaparin or heparin or apixaban, whatever the patient is on, that needs to be stopped because it increases the chances of bleeding. On top of it, if whatever the factors are low, if the platelet is low, they need to be topped up with platelets. And similarly, if the fibrinogen is low, they need to be topped up with fibrinogen. And FFP has a role in DIC as well. FFP, in short, is fresh frozen plasma. I don't know what they use in the US. We do use FFP quite frequently in UK. So bottom line is that the bleeding per se is due to low platelets in DIC, and it needs to be treated as per through the DIC and treat the cause. Hopefully, that will stop the bleeding. And does Meera want to add?
Yeah, I think you're completely right, Suresh. I think initially everything starts out in a prothrombotic state, but there are a few things that can happen later. Eventually, all clotting factors will get consumed, and patients will bleed if the process is not taken care of, because eventually all clotting leads to bleeding if we don't take care of the problem. So yes, if we initially start out with the clotting problem and it is not managed, eventually there is depletion of all the clotting factors in the blood, and that can result in bleeding. The second thing that can happen in COVID is something called ITP. I'm sure all of you have heard about it. It is called immune-mediated thrombocytopenia, and it's not necessarily due to COVID. Any viral infection, or really any infection, can result in a temporary lowering of platelets. And if that becomes very severe, sometimes we can see bleeding problems with COVID. In general, bleeding is easier to treat than clotting. So most hematologists feel that it is easier to treat a bleed than it is to treat a clot. So we err on the side of treating a clot rather than worrying about the risk of bleeding. Of course, bleeding in the brain can result in devastating consequences. So we have to be always mindful of that. But in general, bleeding is a much rarer complication in COVID than clotting.
Okay, great. So there is a next question which I'll probably answer. So it says, what about pregnant women? Is it safe to take COVID-19 vaccine? So the short answer is yes, it is safe to take COVID-19 vaccine as long as they're eligible. Do check the description below. There is a COVID vaccine series. There are a lot of videos related to COVID, and there is also videos specifically on COVID in children, which talks about COVID and vaccines in pregnant women. So thank you for the question. High dose steroids in severe COVID, could it encourage bacterial and fungal sepsis? So Suresh?
Uh, Again, it's controversial. It's debatable. But at the end of the day, the only thing we have found out till now works in severe COVID is steroids. Uh, Steroids is the treatment of choice. We have seen ample benefit by giving steroids. Whether it increases the chances of severe sepsis or fungal infection, it's debatable. But COVID per se can make you to get can make you to get any sort of infection. So there is a recent trend in India about mucormycosis. I think that's a different topic altogether.
Yeah.
But steroids per se, short answer is you need steroids. I don't think it increases any chance of getting more infection than what COVID already does. So you need steroids, bottom line.
Okay. So I guess there is a question on vaccine. So let me see this. There is a report that says teenager hospitalized with blood clots after COVID-19 vaccine shot. So does that happen,
I,
So I think
Meera?
this would only be relevant probably in some of the Pfizer and Moderna, because those are the only, I think, vaccines approved. Like Pfizer, for example, is approved for age 12 and above, and the Moderna vaccine currently is approved for ages 18 and above. So I think if there is a teenager involved, they have most likely got either the Pfizer or the Moderna vaccine, is what I would assume, unless AstraZeneca is also using it for teenagers, which I'm not aware of. But anyway, the risk of teenagers having blood clotting problems is actually very, very rare, and I personally have not heard of any vaccine related blood clotting problems from either Moderna or Pfizer. Now with teenagers, we are seeing, and the CDC is also looking at this, is with the Pfizer vaccine, they are starting to see some teenagers or young adults get something called myocarditis, or it is inflammation of the heart. So it usually is a transient phenomenon, but there have been some cases reported of that. So that is actively being looked at.
Okay.
The incidence of blood clots are mostly seen in your adenovirus vector vaccine. That is typically the ones that are known to have some vaccine related problems. And I'm sure Dr. Suresh will talk more about that. and that is either going to be your Johnson and Johnson vaccine here in the United States, or the AstraZeneca vaccine in the United Kingdom, or the Covishield vaccine in India. So these are the adenovirus vector vaccines. These are traditionally the ones that again have had a very, very small, again, when we say small, it's extremely small a percentage of patients reported to have blood clot. The one thing we have seen with Pfizer and Moderna is some cases of ITP, or low platelet count. Those have been reported. But if a teenager had an issue, I would not automatically assume that that is vaccine related. Like I said, probably would need a deeper dive into looking for other causes as well.
Okay, so Suresh, as you talk, do you also want to say, yeah, have you seen
Yeah,
personally seen any
I have
cases?
the UK data with me till end of May. I think UK has given 24.3 million first dose vaccine, and 13.4 million people had second dose. So out of these patients, 348 patients had vaccine related thrombosis. Out of those 348, 128 had cerebral venous sinus thrombosis. And out of 348, 61 people unfortunately died. So, but 348 out of almost 50 million people is a very, very small number. So, what it's trying to tell is vaccine is needed. I know there is a small risk of blood clots. Usually, it's seen in vector vaccine, which Meera pointed out. Most likely, is Oxford or Covishield, what we call in India, or it's the Johnson and Johnson. But Pfizer is not completely ruled out either. It's still being It's still being looked into. There are quite a few case reports of Pfizer causing blood clots as well. I have my own experience in my place. We have a 20-year-old who had second dose of Pfizer vaccine,
Uh-huh.
and she's been admitted with upper limb DVT, or sinus. I mean, significant thrombus. She had a thrombectomy done, but she's still having significant pain in her arm. The plastics are involved. And unfortunately, our WIT screen has come back as positive. A WIT screen short form is vaccine induced thrombocytopenia and thrombosis. We do something called WIT screen. She had Pfizer vaccine, but still the WIT screen is still borderline positive. So, what I'm trying to tell is Pfizer is not completely ruled out. Still, there are few case reports of Pfizer causing vaccine. So, we should have an open mind, and it needs to be investigated in detail.
Okay. How about Covaxin, Covishield, and other vaccines in India? Do they have a risk of clots?
Usually, I think the first blame is the vector vaccine, like Oxford and Johnson and Johnson. They are the vector vaccine.
Okay.
The majority of patients are Oxford or Covishield or Johnson and Johnson. It's very, very rarely seen in inactivated vaccine like Covaxin. I mean, still it could happen, but it's very, very rare when compared to vector vaccine.
Okay. So, Suresh, let's say someone has a bleeding disorder like hemophilia or any other bleeding disorder, and this is a intramuscular injection which carries
Yeah.
the risk of clots and other things. So, can people still receive the vaccine if they have such disorders?
Short answer is yes,
Okay.
but it needs to be it should be under physician's consultation, because severe hemophiliacs, what you don't want them is to develop a significant IM hematoma, or what hematoma means is a blood clot wherever they give the injection, because they can bleed. So these patients, they can have the relevant factor before the vaccination, so that the factor level in their body is high, and when they take the vaccine, IM vaccine, it causes less harm. And these patients, they can have fine needle for the IM injection. That again reduces the chance of developing any sort of complications with vaccination. Short answer is definitely they have to go for vaccination, but they need to take precautions for developing any sort of hematoma.
Okay. So, Meera, on the same note, if someone is taking aspirin or other blood thinners, before getting the vaccine, can they still get the vaccine without any risk?
Absolutely. I think, again, the answer is yes. Again, most people that say that they're taking blood thinners, if you look at it, they are not blood thinners. They're mostly antiplatelet agents. So majority of people that have to take aspirin, or let's say somebody who's had a cardiac stent placed, will probably be on clopidogrel or Plavix or some other form of antiplatelet agent. They're not traditionally called blood thinners, although many people think of them as blood thinners. So most patients are on antiplatelet therapy, and that is perfectly fine to take the vaccine. In fact, we encourage all patients to take the vaccine. Really, the only contraindication would be if they have a specific allergy documented to the components of the vaccine. If not, the way I try to look at it is their risk of having a thrombotic event from COVID-19 is far, far greater than having a thrombotic event from getting the vaccine. So it's always pick the lesser of the two evils, and vaccination is much the lesser of the two evils compared to a person's thrombotic risk if they got COVID. So yes, the short answer is if you're on blood thinners, antiplatelet therapy, it is okay to take the COVID-19 vaccine.
Okay.
Again, we always have to keep an open mind, and if they have any symptoms after the vaccine, we have to keep an open mind, understand that there could be this small complication, recognize it, identified early, but yes, it should not be a contraindication for the vaccine.
Yeah. So for those of you who have heard me before, you might have gotten bored me saying this. So do get the vaccine if you're eligible to do so, because that's the best thing we have at the moment to prevent COVID infection. So I think we're, probably getting close to winding up. So I have one last question that says, what impact will fear, the clots and other problems you mentioned, have on global vaccination efforts? So will people still be receptive to receive the vaccine? So Suresh, if you want to go first, and then Meera.
I mean, all this media, they are just uh, trying to hype everything. Short answer. I mean, people are a bit hesitant after all the negative media. I think this is what we are trying to encourage by all this. The reason why we are doing this is to encourage people to have vaccination. So I mean, our main aim should be to encourage people to have vaccination. There is a negative media around, and they hype things, uh, but we have talked thrombosis so much. But what I'm trying to tell is, because we are in that field, we see more thrombosis, but that doesn't mean each and everyone who gets a vaccine gets thrombosis.
Yeah.
It's a very small risk, but it does happen. But it doesn't mean that they should not take the vaccination. Uh, our advice is, if you are eligible for vaccination, you have to go for it, and we have to try to avoid this negative media as much as possible.
Okay. Thank you.
So yes, I completely agree with Dr. Suresh. I think this whole vaccination, I mean, if you look at it, this has been quite unprecedented. We've had a new illness that has been discovered about a year ago. Within 16 months, we have 4 or 5 different vaccines that have been approved. And I think as of last month, we have had over all over the world more than 1 billion patients vaccinated. So if you just imagine the scale of how this has happened, it is truly an unprecedented miracle of science. And I think we have to applaud everybody that has worked on it. And it's been a great, tremendous effort. Yes, there is going to be some skepticism anytime there is a new treatment or a vaccine that comes out. And to be fair, I think the skepticism is reasonable. It is fair enough. I think we have to be skeptical about any new thing that comes out, any new drug that is marketed to us, or new treatment. But the skepticism has to be based on science. It cannot be based on what your friend says, or what you hear in the media, or what. So the skepticism is real. I think it is important for us to be skeptical. If we perceive that there is a side effect, like for example, AstraZeneca and Johnson and Johnson, anytime they perceived that there was a risk, there was a halt in the vaccination process. We reassessed all the risk factors. So I think that shows us that the process is very much intact. This is how science is supposed to work. Our recommendations may change, but I think the bottom line is, yes, this has been a new vaccine. We still don't know some of the long-term side effects and all that. skepticism has to be real and is reasonable, but please base your skepticism based on science and not on other conflicting factors. And the science so far says that the vaccines have been effective and it prevents some of the long-term complications of COVID, short-term complications of COVID. And I highly recommend for anybody who is able or has access to get the vaccine to get it.
Sure.
Even though there are small side effects in the numerator, the denominator is very huge, and I think we should constantly remind ourselves of that.
Okay, great. Thank you so much. So I really want to thank all the viewers for hanging on, asking those excellent questions. And thanks to Dr. Meera, Dr. Suresh for taking out your time. I know you're so busy. You're the world experts in this area, and I want to really thank you for both being here.
Thanks.
Thank you,
Same
Raj.
here, Raj.
Yeah, we'll
Thank
talk to
you.
you soon.
It was
Bye.
great answering these questions.
Yeah.
These are things we struggle with every day in our practices. So it was great discussing this on a platform like this.
Yeah.
I hope it benefited somebody.
I'm sure it is because this is a very confusing topic, as you can imagine. I'm a physician, but it's so confusing for me, so I can only imagine what happened to
We
And
are
it is
still
a very
learning.
nuanced.
Sorry, we are still learning as we go by.
Yeah, this is absolutely, this is a learning curve. This is a new disease. By the time something is written on it, it's already old because, as we know, things are changing so constantly. So it's been pretty confusing. So again, we're all learning and,
I,
thanks to all
I, I,
of you.
Thank you, Raji. I was told there is 1 lakh papers being published since COVID came out, so I don't think anyone has time to read
Oh, is
those
that
one
what it
lakh.
is? 1 lakh papers?
Yeah, just on COVID in the past 18
Wow.
months.
That's unbelievable. That's
Yeah,
unbelievable. So it just says the impact of what things are, and it only gets more confusing because if you have more, obviously we can read more. So we as physicians too, as doctors too, are learning things every day as we move on. And I think as a physician group, we are doing our best to make sure patients stay safe, and we educate people to do the right things.
yeah, that's our main aim.
Absolutely.
Yeah.
All right. Thank you so much.
Thanks,
Thank you.
Rajiv.
Bye.
Bye. Bye.
Bye.